So we are going to transition on in our agenda for the report out from the roundtables and get us into thinking about recommendations for advancing respite-related research. Next slide. So I want to invite and thank our panelists for joining us today. You can see their names listed here. We have Dr. Joseph Caldwell, Dr. Ray Kirk, Sue Peshin, and Dr. Cordelia Robinson Rosenberg, who are joining us as panelists to share their thoughts as they were participating in the roundtable discussions. Next slide, please. So I'm going to jump right into it with our panelists and ask for them to just briefly report out what they feel were key insights from their roundtable discussion. So we're going to start with Dr. Caldwell. If you want to take a few moments to share, first tell us which roundtable you're in and then share some of the key insights.
Sure. So our roundtable was focused on systems change to improve access to respite. And it was an excellent group, and Susan did a great job facilitating. So we had a lot of good, rich discussion. You know, I think just to try to, you know, group some big themes that came out. I think one is just the lack of baseline information of who has access to respite. So where are we starting from? You know, who's getting respite? Who's not getting respite, where are the gaps? There's just, it's hard to get that information, particularly at the state level. There's, you know, not very good data systems that sort of provide that information right now. So there was some discussion about, you know, what we could do to work, you know, within states. And one of the things that stuck out to me was this challenge because it is this, you know, across population sort of approach. And so each system within the state has their own data reporting systems. And one of the ideas that came out was having, you know, first of all, the common definition of respite, which ARCH has sort of, you know, really helped develop, but also like common one or two questions that could be added to those systems so that you could get some better information across different systems. So that was one area. The other area where there was a lot of rich discussion was just sort of awareness about respite, outreach and awareness to families about respite and increasing, you know, the access to respite. And a lot of good discussion around ideas to improve that. I would say one state shared they were using ambassadors, and there was a lot of excitement about this in terms of using ambassadors or community connectors to reach, you know, underserved populations, racial, ethnic populations, LGBT community, and other diverse, you know, populations that are being underserved. So I think more research in that area. There was also a lot of discussion about partnerships, you know, with the private sector, so health insurers in the health system, and particularly physicians, is in terms of them being a conduit to share information to families about respite and access to respite. We talked about some of the challenges to that, but I think there was a lot of excitement about that, particularly to reach some racial ethnic minority populations that are being underserved. There was also a discussion, you know, just partnerships with USEDS. You know, a lot of the lifespan respite coalitions are working with their USEDS, and that being a good partnership. Also partnerships with community colleges in terms of some of the workforce issues was discussed. I think I'll kind of stop there. Those are the main themes that I sort of pulled out of the discussion, and there was a lot more to it. So, but that's the main themes that I pulled out.
Thank you, Dr. Caldwell. Dr. Kirk, if you could share what group you were in and some key insights.
I was with the best group, group 1. I didn't have to use a single probing question, and the whole group is proud of that. The first question relating to the basic concept of outcome measures, and where do we go with that? There was a lot of information shared about, and it harkened back to some of the comments made yesterday and earlier today about the measures not necessarily being relevant to the families being served or the communities being served, or not being a good fit with those communities, even though as researchers we might think, well, we have a good standardized test for this particular outcome measure, or we have an interest in it from other research that's been done. And some of the insights offered by members of the group were that the measurement windows that are available need to be considered. And by that, I mean, if you ask someone about their level of depression since they began receiving respite, is that a week or a month or 6 months? Is there a possibility that that has taken some time to change or hasn't changed yet? So there's some, we really got into some of the nuts and bolts of the design construction, even though it wasn't couched in those terms. Sensitivity of measurement instruments was an issue. There was a call for more process outcomes, such as a sense of engagement with the caregiver and the family. Do they feel they've been respected? They feel they've been treated well? If they're willing to participate in studies and share their life story, or is there a sense of gratitude to share that information? I think I got that one correct. Someone said the best outcomes measure what families need and want to have change. So again, rather than imposing our academic view or our research-based view, perhaps the discussion needs to begin with the families and say, if respite care were successful for you, what would change? What would you want to change? What would you look like if after an episode of successful respite? So it's kind of a different focus in terms of the origins of the outcome measures. In terms of barriers, and this was very interesting to me, it was suggested that we give ownership of the studies to the stakeholders, particularly with respect to of minority populations and hard to reach populations, so that there's a sense of them actually giving back or receiving for themselves and giving back to their communities this information that would help us improve the service. Another very interesting comment was the notion of a single caregiver does not necessarily work across all cultural, racial, ethnic constitutions of treatment populations or service populations. That was raised in particular with relation to the Native American or American Indian population, where they don't see the construct as a single caregiver responsible for the care receiver, but rather it's a family effort or a family system or a tribal or community system. Barriers of imposing a priori assumptions on the study design. They're not always a good fit for the community. One of the most, I think, compelling, and this is really a big system kind of issue, we had quite a bit of discussion about it that grew out of the mention of the availability of some waivers in a variety of different programs. And in some cases, waivers are a blessing. In some cases, they're not, because they may be access to the waiver relief may be predicated on a particular level of need or care. And so if your care receiver doesn't rise to that level of care, you're not eligible for the waiver support. So it creates different levels of access to care when in fact the waiver was intended. It's interesting to me how much the conversations got really into the meat and potatoes of constructing measurement systems, of identifying outcomes that work, and sharing that process with the community that we're trying to serve. So I don't have any idea how I'm doing on time, so you'll have to
I
tell
think
me.
that's great, Dr. Kirk, and I just love the equity lens that you shared, and even Dr. Caldwell's. I think that's great that there was a good focus on equity and that patient family centeredness in a lot of the conversations. So I think we'll move on to Sue Passion and see if she could share her insights from her roundtable.
Sure, and just ask other folks who are in our roundtable together to just, put your extra thoughts in the chat if I miss anything. I did also just want to give a thank you to Kim, who facilitated our group and has been facilitating this whole thing. And you're just such a great light, and you've done such a great job. So thank you. We were cost benefit and cost effectiveness research, and we would thumb wrestle Ray for the best group. I think these guys did a great job because this is a very challenging area, and there's a number of different reasons why that we discussed. One was Kim started us off asking us if resources weren't an issue, what would we want to see? And I think a big theme that came out was a lot of these types of studies are very short. They might be 3 to 5 years in length, and folks were saying that it would really be good to see, even before people identify as needing formal care, what that looks like, who needs the service, what their situation was, almost a population type level study, which is usually reserved for different models of research studies. So that was kind of a dream area. Also, questions were raised around, would younger people be able to work and contribute to society if they receive these types of services? And I thought that was a good question, because oftentimes we're kind of over-focused on the older population. We mentioned in terms of measures, there was a lot that came up with this, looking at things like reduction in emergency department visits and hospitalization, but that measuring avoidance of something is challenging. Certainly the delay of entry into institutionalized care. Also measures for better health status of caregivers. Oftentimes, and this is how we started the conversation, we talked about how you want to, make sure that the caregiver gets the services, but that results in cost savings on the care receiver end. But the point was made that you also need to look at cost savings on the caregiver end, that can result in better care, better health status for the caregiver, and that should also count. We also talked about in Ireland, how they have a health system that allows them to track people over the longer term, and how in the United States, these different types of services are very fractured, and we're not able to capture over cross agencies when folks are receiving these types of services and how it interacts with their health status. So Kim actually mentioned doing some research on integrating this into electronic medical records. And we also talked about whether or not there were existing studies like the Health and Retirement Survey or the Baltimore Longitudinal Survey that might be able to be tapped into to see if they could integrate respite there. In terms of barriers, certainly the theme that we've heard throughout this whole thing, and I think has been going on for a number of years, is just how to define respite. who pays the costs and who is reaping the benefits was seen as a barrier. So for example, if ACL is funding a program, but Medicaid reaps the benefits, then who pays for the research? And then also, does it count? Does it matter if the savings are not given back to the agency or the group that is funding the program or funding the research? We also talked about how the benefits of respite are difficult to monetize, like being able to live where you want to live and quality of life. And just sort of the overall, what is the cost benefit of quality of life? Then one of my favorites was the DA factor, which I think Todd brought up, which is when you know something's going to be beneficial, do you need to actually prove that it's cost effective? And I think, you know, everybody says, yeah, that makes sense. But on the other hand, it is good for additional support in the future to know if it is cost effective. And then the issue of dose of respite was also brought up as a potential barrier. And then the last was scale issues. Funders are only willing to go so far until they see the savings. In terms of the last area of questioning, we talked about dissemination and all of that. And I think a great tip that was provided for almost any type of dissemination is making sure that you provide food when you're talking about it. Snacks are always good, and making it user-friendly. Also putting it in a language that's understandable and inclusive. Also in terms of just using language different from respite, if that's what resonates with folks. And then we talked about, in terms of strategies for engaging actual respite providers, family caregivers and all that, PCORI might be a good place to go, the Patient-Centered Outcomes Research Institute. That's an organization that was created as a part of the Affordable Care Act. And they have actually entered into partnerships with different federal agencies. So maybe that's something we might want to pursue with ACL. So I think the themes were what's important to measure, how to measure it, making sure we use the right language, and how do we get data that's meaningful.
Thanks for that great summary, Sue. And last but not least, our last group that we need to hear from is Dr. Cordelia Robinson Rosenberg.
So the group that I was in was considering issues around competency and training needs of providers. And there were a number of themes. I guess part of what I'd say is, who delivers the respite care, or whatever we elect to provide it, to call it, is really essential, and yet probably an underappreciated area. I think one of the key themes that came out was, what do we know? Do we know anything about whether competence improves the actual outcomes? And don't think that there's a whole lot of information on that. One strategy that came up was to catalog what we know of existing training programs and create opportunities such as the Roundtable to share and access this information, but it needs to be put in some kind of organized form. We heard about several exciting training programs today. We need more of that information put together. One very interesting theme that came up early was some programs have systematically involved caregivers in the training of the respite care provider. And along those lines, one strategy that can be helpful is actually, creating coaching templates, using technology to document aspects of care, and as a vehicle for training care providers. And I know in England, and I haven't heard about it lately, they developed something called wikis And these were, short videos that really broke down kind of technical care routines so that the person supporting care could replicate what the primary caregiver was doing. One of the themes that came out was the need to differentiate between paid and volunteer providers, in that there's various rules and different expectations that you can have for each one, that we need to insist upon as programs are funding accountability in terms of documentation of the quality of care that's given. I would argue that we need to systematically, that there's certainly common competencies, but probably need to differentiate some between different populations in terms of the specificity of care that's needed. And another key point was that values and beliefs are an important part of competencies, not just skills. And I would invite other members of the group to pick up on key points that perhaps I've missed.
Great, thank you so much. Again, feel free to continue to post in the chat as well, and also document in your discussion guides. Again, we'd love to have any additional thoughts you have sent in to us and shared as well. So thank you for the panelists for sharing their report out. I want to transition to the next question and the final question for our panelists. And we have 2 minutes or less to share this response. So want you to think about, what do you believe is the most important next step for advancing respite-related research from your perspective? So we will start with Dr. Caldwell.
Well, I'll just reflect on the group that I was in, and there were a lot of state officials in that group. And I just think there's a lot of things that they're doing right now, like this issue of trying to increase awareness about respite, that could really be great, research projects for USEDS or for universities to kind of, to study. So I think there's an opportunity there to just sort of, build some research into some of the practices that these states were doing around outreach using ADRCs or these ambassadors. So that's what I would share.
Great, thank you so much. I'm going to skip Dr. Kirk because I want him to go last so I can transition it off to him. So I'm going to go to Sue Peshin next.
Okay. I would say additional partnerships that can kind of elevate the research and money.
Great, thank you. And Dr. Rosenberg.
And certainly I would echo the money, and I think a real pulling together the information about what do we know about the competence in care delivery, and what training or what skill building techniques work best in terms of engaging and creating that workforce.
Great, thank you. And then finally, I'm going to pass it off to Dr. Kirk to share what he feels is the most important next step, and transition right away. Ray, you can just take it over from there to talk about what the next steps are and wrap this up. But before I do that, real quick, I just want to thank all of you. This has just been an incredible summit, and I am so excited to have had the opportunity to engage with all of you, and I look forward to many more opportunities to collaborate and to connect. So let's not make this the last of the conversations that we have around this important topic. So I'll pass it off to Ray for his thoughts, and he will wrap us up today.
Okay, thank you, Kim. Well, with regard to the last question relating to the roundtables, there seemed to be a very strong sense among the folks in our group, and I sensed it in some of the comments from other groups as well, that we need to, if not re-engage, at least examine the extent to which we are engaged with the caregiver community and indeed respite receiving family community. Do we really know enough about their needs, or are we imposing our research predispositions as we ask them to participate? Good suggestions along those lines with respect to using mixed methods research, perhaps more of an emphasis, not to the exclusion of quantitative measures, but more inclusion of qualitative measures so that we have a better understanding of what the numbers mean. So I think that's points well taken from that conversation.